I like for things to be conversational, so certainly if you guys have any questions or comments while I'm talking, please feel free to raise your hands and we'll speak. And you just ask your questions at that time. Chances are if you're thinking about something or wondering about it, somebody else is too, so it's always good to ask those questions. I'm going to talk a little bit about who I am and what I do. You want to advance the slide would be good. And just kind of, all right, all that's talked about is my journey. So there are multiple ways to go through life, definitely different ways to get to the same place. I don't think that any one way is the right way. Mine was the most direct, and part of that was because I didn't really know what I wanted to do when I was going to high school, so I told people I was going to go to medical school, and I started studying biochemistry. That was a mistake because there's a lot more chemistry than biology in it, and the way my mind processes, I think biology would have been better, but either way, I enjoyed it still. Went to college at UC Davis, which was a California school in the middle of the state, and then I went from there to medical school. I went to St. Louis University up in St. Louis for medical school, and after 4 years there, I did my residency in pediatrics, so that's where you spend 3 years specifically, residencies where you learn about one specific thing. And then I graduated from my residency program in 1997, which makes me feel old, but 26 years ago. And I practiced as a pediatric hospitalist for a number of years, and then decided I wanted to go back and do more training, and I did 3 more years in neonatology. And that was working in an intensive care unit, taking care of babies, the majority of which were premature, all of them which had medical conditions. And then after that, I came back here to work and worked at Southeast Hospital since 2008. So I was going to come back for a few years and ended up being back here for 15 and still going. So I guess one of the other things I'd add to that is you could probably never guess where you're going to be 5 years from now. So it's okay, it's important to make plans, it's good to work towards something, but it helps if you're just open to the opportunities that come your way. Because like I said, I would never have considered myself working at Southeast, in Southeast Missouri, at Mercy Southeast 15 years later, but I absolutely enjoy it. So I consider myself one of the luckiest people on the planet for a number of reasons, but one of them is because I enjoy my work, and Olive can tell you, I never have a problem going into work. I go to work almost every day, and it's just an incredible thing to be able to do. So if you can go to work and do something that you love doing and work with people that you enjoy working with, that is just an incredible gift and something to be grateful for, and I have that. Moving on, medicine is so I think we might be losing the top of these slides. I don't know if it certainly isn't important at this point, but at some point things might get chopped up. But anyway, all right, boom. Yeah, maybe we'll just try to keep it there. Okay. So, healthcare is for everyone, and it doesn't matter what you do. I think that if you want to go to the next one, people, when you think about providing health care, everyone thinks about doctors and nurses, but certainly it takes an entire team to take care of any patient, but especially babies in the NICU, but it also takes people with incredibly different skills. So if we go on to the next one, and then if you look at everyone who works in a hospital, you certainly have nurses and physicians, you have phlebotomists, which are people who draw blood, you have chemists and people who work in the laboratory, you have people who work in administration, you have electricians, you have plumbers, you have people who keep things clean. Moving on to next, we have people in the legal department, we have cooks, all right, dietary, there's every single field. The hospital is almost like its own working little city, if you think about it. And in the NICU, so you think, okay, you're just in this one area. But once again, we have a number of different professionals who come in, and every one of them plays an important role in delivering the best care. I sometimes feel guilty when I see like a little kid that I took care of as a baby, and people come up to me and they thank me and they tell me, you did such a wonderful job taking care of my baby. I'm so happy that you did all that. And I think no one goes up to our house cleaners and tells them, my baby was in the NICU and you did such a wonderful job, because you might think, well, that job's not that important, but they wipe down all the counters, that's all they're doing, but they're helping to reduce infection spread in the NICU, and that's critically important. The people who stock the little bins that has all of my equipment in it, if they don't do their job right, and I have a baby that I need to put on a ventilator, and I need to get that tube to put into down that baby's throat, into their trachea, and it's not there, then I can't do it. And so I need everybody who comes into that NICU or does any part of it to realize how important their job is, because everyone contributes to us taking a baby that is sick and having them go home healthy. And I always, as much as I can, tell everybody in the NICU, thank you for what you're doing a great job. The person who comes and does the x-ray, if they get there in minutes, that certainly helps that baby out than if it takes them an hour. So they need to understand how important every role is. Okay, moving on. Premature birth affects so many aspects of both the baby and society. So as you can see, this baby is about 25 weeks. A normal pregnancy should be 40 weeks. And we generally consider a full-term baby 37 weeks or 38 weeks to 42, depending on who you talk to. But this baby is born at 25 weeks, so 15 weeks early. You can see how small they are. They're like as big as this person's hand. There is, I don't know if you can see, a small tube right here that is going down into the baby's mouth and into the upper part of the baby's trachea and helping the baby to breathe. It affects the baby physically. It affects the family socially. If you have a baby that's premature and in an intensive care unit, that's an incredibly stressful time for you. It puts a lot of stress on the family. It helps if you can have your community around you and people who support you. But sometimes when people are going through stresses like this, they don't want to talk about it. So I always encourage people who have their baby in the NICU to talk to family and make sure that they're getting the help that they need. It affects them financially. It affects all of us financially if you pay taxes, because babies that are born early cost a lot more to take care of than babies that are born full term. If you look at the average cost of a stay in the NICU, it's somewhere close to $100,000. Whereas if you're looking at the cost of a baby who just goes into the well-term nursery and goes home from there, it's more like about $3,000 or $4,000. And that gets paid by somebody. It's not paid necessarily by the family, but insurance. I don't need to go into economics for you, but everybody ends up paying for it somehow. And in a way, it affects you, because you are going to be both, one, maybe paying taxes, but two, members of society that were born premature for some reason are out there around you. And so in some way, it's going to come in contact with you. Right, Olive? Maybe. No one's going to come in contact with someone who was born premature. Anyway, in this room. Next one, slide. So if I'm going too quick or anything, just let me know. I want to go through this kind of stuff, and then we're going to get to the real star of the presentation, but also kind of just open it up for questions and all that. So some statistics. So we have about 4 million babies born in the United States each year. Okay, and about 12% of those babies are born premature. So that ends up, it seems like it's a small number from the whole, but it ends up being 480,000 babies a year. And since 1981, that rate has increased by 31%. And the rate of the babies that we call late preterms, which are babies that are born between 34 weeks and 37 weeks, has gone up by 40%. And part of that is due to artificial insemination, reproductive technologies. Part of it is due to our ability to care for babies better and move some of those real premature babies into that late preterm area. There's just a number of reasons for that, but the thing is, there's a lot of premature babies out there. And one of our goals is to reduce that and get those babies full term if possible, because it makes things easier on them, the family, and everybody else. Next slide.
Can I ask a question about that?
Sure.
So, this might be, I don't know how to ask this without just saying it, but what is the survival rate of premature babies?
Yeah, so that's going to vary based on what week you're born,
okay.
Right? So a lot of times it's classified that way. So in my mind, I think of 24 weeks as the first milestone. There have been a few reports of babies born at 22 and 23 weeks. Those babies have a very low survival rate, like 2 or 3 out of 100. And then those that do live less than 24 weeks, a lot of times have a lot of long-term neurologic complications. The problem with babies that are born that early is there's really no lung development. And so what happens first is you develop the tubes of your lungs, which is your trachea, your main bronchus, and then bronchi as you move down. And you have these things called respiratory bronchioles, which are tubes that can exchange a little bit of air, but you don't really have a lot of the alveoli, which is those little like balloon-looking sacs that really increases the surface area and allows a lot of air to be exchanged. So those babies, a lot of times, you can't oxygenate them, you can't get good air exchange. And then the other problem they have is our lungs want to develop in a wet environment, so there's no pressure on them. It's kind of that lung tissue is just floating in fluid. That's fluid that the baby, amniotic fluid that they breathe into their lungs, but also the lungs are actually making fluid for the lungs to grow in. And when they're born, your lungs dry out. And so now the lungs have to develop in a period where they're dry and under pressure, and they don't develop appropriately. They have a lot more scar tissue, and so those babies have lots of breathing problems as they get older. But once you hit 24 weeks, if you've had pretty decent care and you can get some what we call steroids in, which kind of gives them a little boost, about 80 to 85% of babies after 24 weeks are going to live. Yeah. Now, a lot of them will continue to have neurologic complications, but many of them won't. And so you really run into this gray area of how much of a decision do families get to make on how much we do to keep these babies alive. Because certainly a baby born at 24, 25 weeks is going to be on a ventilator, is going to be on IVs for a number of weeks, and is going to have a lot of medical interventions. And the question is, how much of that should we do? And generally, we gauge that based on what kind of quality of life we think that baby is going to have. And certainly at 24 weeks, the potential for a quality life is there, even though we don't know it. As time goes on, you might find out that the baby had a massive stroke or something like that, and they make a decision that maybe it's not fair to this baby to put him through all these medical interventions, some of them which can be painful, if they're not going to have a quality of life afterwards. Once we get beyond 28 weeks, those babies have almost the same survival as a full-term baby. So 28 weeks, you start looking at survivals, 95 to 98. Definitely once you get to 32 weeks, you expect the same survival as full-term babies. Now they're going to have more medical issues at birth, of course, and then they're going to have the risk of long-term problems. But at the same time, even those are less frequent once you get beyond 32 weeks. So that 32 weeks in my brain has always just been like a big milestone that you hit in order to have a healthy baby. Certainly we want all babies to be born 38 to 40 weeks. But if you look at prematurity rates in Missouri, like I said, it was at 12%, it's 12.1. And this one, there are some nations that have it down as low as 6 or 7%, kind of in that range. Our goal is to get to 9.6, which might not seem like a big drop, but if you take 2.5% of 4 million, that's 100,000 babies. So, it's small increments can make quite a bit of difference. And if it's your life, if it's just one's important, right? So we try to do everything we can to reduce any of these risks for these babies. Next slide. So here's a little premature infant. This baby, you can really tell that they're about 24, 25 weeks because of how glossy the skin is. They're very shiny because the blood supply to it. The skin's very thin. There's really no subcutaneous fat on it. This baby is intubated. That's what this little tube going into the mouth is. Probably has a feeding tube also, and probably an umbilical line. I'm just going to briefly hit a few of the procedures we do, just because it's somewhat interesting, I think. Next one. An important thing to remember about fetal development is that it actually begins prior to conception, which might seem like a weird thing, but the baby's health is really dependent on maternal health. So if mom has medical illnesses, having those in good control is important. If you look at, say, a woman with diabetes, if she has poor control prior to getting pregnant, that baby's more likely to have birth defects than if she has good control. So things that I really think are important is for us to promote good health among just every adult and teenager and child in our society. But
how much would you say drugs affect the kid?
so drugs, that's once again kind of a hard area because it's such a big range as far as the different types of drugs that are used. I have not come across a drug yet that has been beneficial to a baby, and so I would say that generally drugs in pregnancy is not a good thing. And that seems like a weird thing to say, beneficial. We know that cocaine actually advances the baby's lungs development, but it advances the baby's lungs development because it stresses the babies out. So it's almost like the baby starts to prepare to be born early, and so their lungs develop a little bit quicker. It's not because it's doing something good for the baby. That also increases the risk of the baby having a stroke, both in their brain or in their intestines. It also increases the risk that mom has what's called an abruption, which is when the placenta pulls off of the uterus early before the baby's born. And obviously that's the supply of blood and, well, not blood, but oxygen to the baby. So if that placenta pulls off, then you end up with a baby who's in a lot of trouble. Most drugs negatively impact the baby's brain development. Probably the biggest cause of preventable neurologic problems, developmental problems in children is fetal alcohol syndrome. So a lot of people, when they think of drugs, are thinking cocaine or opiates or meth, and which are not good for the baby at all. However, alcohol, because it's so prevalent, is probably the #1 cause of mental deficiencies for growing children. It's kind of a spectrum, meaning you could have someone who's exposed to some alcohol and they have very little effects from it, and then you could have others that are devastated. I have another talk just on prenatal drug exposure that kind of goes through all the different ones. So, but certainly drugs in our society affect babies. I've taken care of probably at least once a month, sometimes more than once a month, babies that are exposed to opiates and have withdrawal syndrome, withdrawals from the opiates that mom was taking, both illegal and prescribed. A lot of women who are addicts take either something called methadone or buprenorphine, which are two medications that helps to control their cravings and it helps them to function in society. However, it does cause withdrawals in the babies. So we recently had a baby that was in the hospital for close to 60 days, just withdrawing from the buprenorphine medication that the mom was on. That drug is really long acting. The way I treat the babies, it seems kind of odd, but I actually put them on morphine, and we put them on really small doses of morphine to decrease their craving, and then slowly take it away as the baby adjusts to the new dose, each lower amount. Babies that have been exposed to opioids are very irritable. They have trouble eating. They constantly want to eat, but then they're dysfunctional what they're eating. They're constantly crying. They're not sleeping. They develop diarrhea. They have all these symptoms that just, if you see one, you just realize how upsetting it is for them and how their body is just reacting to it. And then so you put them on something to calm that down, but then you have to slowly take it away. Methamphetamine definitely affects the neurologic development of babies. It also increases the risk for ADHD in children. Marijuana is a difficult one that we don't fully know yet. However, It looks like it's going to cause developmental issues for babies that are exposed to it in utero. The thing about marijuana is, or THC, is it likes to concentrate in fat, and babies have a lot of fat on them. So their brains are all fat. And what was the other thing I was going to say about that? Oh, and it also gets into the breast milk because there's a lot of fat in breast milk. So she's all like, yeah, I probably should have done her for doctor. Anyway, so it also gets in breast milk. So currently, the recommendations are that women should not smoke, or take THC gummies. It doesn't matter what form you're getting in while you're pregnant, and also should not breastfeed if they're using THC or marijuana, because it does get in there. The important thing to also remember about this whole thing is that babies develop really quickly. Like the first 7 weeks after conception, there's like a whole lot of development and changes going on. So especially with alcohol, people who drink regularly are like, well, I stopped as soon as I found out I was pregnant. But the problem is a lot of development's already occurred. And small changes in the first couple weeks can be amplified as you grow and develop. So anyway, so I tell people they should stop drinking if they're planning on getting pregnant. I don't personally have a problem with people doing things that are legal and figuring out what's right for them in their life. But I also think that when you decide to get pregnant and carry a baby, that you now have taken on the responsibility of another life, and that you owe that responsibility to that person to do the best you can for them. So one of those would be not drinking and not using marijuana or smoking cigarettes even. Folic acid, it's a vitamin B9. It decreases the risk of neural tube defects. So these are things that if you supplement your diet with this before you're pregnant. So folic acid is now in everything. It's in bread and pasta. They do all that because it reduces the risk of these neural tube defects. And that's what this picture is. The posterior part of this baby's skull didn't fuse, and so part of the brain is sticking out. So the back part of the neural tube, which should hold everything in place, is opened up. And so by taking folic acid, you can reduce the risk of those things happening.
So when stuff like that does happen, will the baby pass away? Or?
It depends on how severe it is. So I've seen babies with very small ones, about the size of a marble. And a lot of times, while that tissue itself isn't going to be as helpful and needs to be removed, if the majority of the brain is okay, the baby might not have any effects from it. I had a baby recently. You don't see them very often, but we had one recently who had a defect in the middle of the spine. So if you go halfway down the kid's back, it was opened up, and so it was one of these defects. But I don't suspect that baby would have any problems because they were moving their legs and everything seemed to look like the nerves going down to the lower part of their body was working just fine. But those are kind of things you won't know until as you follow the baby. But not all of these are deadly, Next slide, please. I'm going to keep moving on. So fetal development. So the rudimentary heart develops by about 5 weeks. So that's not like the way your heart looks right now with 4 chambers and the blood, everything. It's more of an outpouch of the vasculature, but it does beat. So it's a rudimentary heart, and it's there at 5 weeks. The whole structure of the spine and the spinal cord and the brain is developed by 7 weeks. So all major organs pretty much have differentiated by 7 weeks after conception. So given that, it tells you how early on it's important to be in a healthy state. So I think just like every now and then I just stand on a little soapbox and say things that maybe, but I think if you believe in the right to life, then you should believe in healthcare and providing healthcare to adults, because by making our population healthier, we're going to make babies healthier. Next one. So the most important time in your life is actually those first 9 months, which hopefully should occur inside your mom. During that time, you start out as 1 cell at conception, and you have over 50 million cells by the time you're born. your size grows over 500,000 times. And like I said earlier, it happens pretty quickly. You go from being microscopic to being 3 inches long by 13 weeks. And 3 inches long might not seem very big, but when you were invisible, in essence, not being able to see, it's a lot of growth. If you kept growing for the first year of your life, as you did in utero, you would be like, I think it's like 85 feet tall or something like that. I mean, you would just be huge. So, next slide. And that fetal growth, while we really concentrate on the early side, it's important all the way up to full term. If you look here, these are the weeks along, and you look at the baby that's 32 weeks, weighs 1,700 grams, which is like about close to 4 pounds, a little under 4 pounds maybe, whereas at 40 weeks, it's under the little eraser, but I think it's 3,500. Yep. Well, it's still there. It's 3,500 grams. And so you double in size during that last 8 weeks. So even though when I'm taking care of a baby at 32 weeks, they've got eyes, they got a heart, they got a brain, everything is structured, their kidneys work, their liver works, they still have lost out on a lot that occurred during that last 8 weeks. During that last 8 weeks, not only the organs differentiating and the lungs are learning how to work, but the baby's storing up all this stuff it's going to need at birth, like fat and fluid and sugar. So the sugar is stored in your liver and something called glycogen. And so it stores, all that gets stored up in the last couple of weeks because it doesn't need it early on. So the body's like, well, I'm not going to store this stuff. I'm not going to need it for another 20 weeks. But then when they come early, they didn't have that opportunity to do that. So. Yep.
Is being born late also bad?
Is what?
Is being born late, like at, say, 42?
Yeah, so there's a couple of reasons. I rarely see that now. So I used to see that quite a bit, like about 20 years ago. But most of the time, if you hit 39 weeks, people start thinking about inducing the pregnancy because that's probably the healthiest time to be born. If you look at risks and benefits and you plot it all out, 39 weeks seems to be the healthiest time. If you're born late, what happens is now you've outgrown your placenta. So the baby is big and wanting to grow, but the placenta is not able to give them enough nutrients. So the baby ends up getting that energy from itself. So a lot of times when you're born late, those babies will look like they're wearing skin that's too big for them because they've started to take all the fat that's in their subcutaneous tissue out and using that for energy because their brain is very is selfish. That's probably the right word for it. The brain's like, look, I need energy, and I'm taking it from anybody. And it takes the fat out of the skin in order to create energy for the brain to keep going. So yes, so being born late does that. The other risk is if the baby has a bowel movement before they're born, that stool is called meconium, and it starts to float around in the fluid. And it's sterile, so it doesn't have bacteria in it like all of our bowel movements do. But it is irritating to the lungs. And so some of those babies will be born with severe lung disease because all that stuff has gone into the fluid, into their lungs, and then now they've got like a chemical irritation to it. If you think about like when you get stung by a bee or something like that and your hand swells up, if it's swollen, well, think about it, their lungs are like that. And if they're all swollen like that, then it can't pass the air, so it can't exchange oxygen, and we should. However, even their intestines are immature and are not ready to process protein and fat and all that. So we have to give them just a tiny amount of nutrition, let their bodies adapt to that, and then increase it, and then increase it. So I start most babies off at about a teaspoon or a half a teaspoon per feeding, and then slowly ramp that up as their intestines get to adjust to the different proteins and fats and sugars that they would not normally be processing at that time. Okay, next slide. So happy birthday, right? The baby's born. We got our next one. So I'm just going to just quickly through a delivery real quick. So baby's born. This is what we want to see. Full-term baby. You take them, they come out. You put them on mom's chest. You dry them. You warm them. You stimulate them. They cry. We're all good. So this is what happens 95% of the time. So this is nice. But for that 5%, I highly recommend being born in the hospital because you can't always predict it ahead of time. I'm not a big fan of home births just because of that. But next slide. So then here's a baby that's not breathing. If you look at this baby, I mean, you can't see a whole lot, but you see how floppy the kid is. And if you could see this picture a little more clearly, you'd see that they're very blue. So they're not oxygenating well. They're not screaming like that other baby. We like screaming babies because screaming babies are breathing. And this person is looking in the mouth because he's going to put a tube down in order to ventilate the baby. So breathing is like the number one thing you got to do at birth, right? Because mom's providing 100% of the oxygen. You cut the umbilical cord, you have zero oxygen coming to you at that point. So unless you start breathing, you can't do it. So that's why we focus so much on that. The other things we can figure out later, but breathing. So most babies, you stimulate them, you suck out their nose and mouth with a little blue bulb, and they're fine. Every now and then, some of the babies are not breathing very well, and we need to help them out. So the easiest way is with a mask. So you put a mask over their face, and you have this little bag, and you push it, and you put the air in. And then once the baby starts breathing, it just like wakes them up, and they start breathing and screaming. And that takes care of the majority of babies that need any kind of help. But every now and then, you kind of go down this track where we end up having to do more things. Yeah.
A couple years ago, I helped this guy at my church help, his goat have a baby, pulled it out.
Yeah.
And we had to shake it upside down because the mucus was in the lungs. Do you have to do that to the babies? Or?
So we pretty much don't shake babies. Yes. So never ever shake a baby. You can stimulate a baby, so we'll rub them, and a lot of times they're doing it upside down because they're trying to get any of that amniotic fluid out of the lungs. But a lot of times you can just use a bulb and suction it out of their nose and mouth. So there are ways that are less traumatic than shaking. But you do see the old pictures where they pull the baby out and they slap its butt, right? That was like the thing. And you kind of stimulate it, and they're holding the baby upside down. We don't do that anymore, but that's kind of like old images I remember when I was growing up. There's this great YouTube video, I don't know what it is, but I call it Elephant Neonatal Resuscitation, where this elephant gives birth and the elephant's not breathing, and the mom elephant just starts thrashing it around and doing these things, and then it just kind of wakes up and breathes and gets up and walks away. You're like, wow, that was crazy. Yeah. Yes, Olive.
You know how if you're upside down and the blood rushes to your head or whatever? Does that do that to the baby whenever you're?
It would do that to the baby too. Yeah.
How long does it take it? How long does it take to get
The blood back down?
Yeah.
Well, the blood's still going to go throughout your whole body. It's just concentrating more there. It's more of a pressure issue. Your veins know how to push the blood to your heart, and your heart knows how to push it throughout the blood throughout the body. But since we don't hold babies upside down, I don't really know how long it would take for them to resolve it, because we're not going to try it. Yeah, we're not going to do that experiment. All right, our next one. So this is a baby. These are different babies in the first hour, concentrating on breathing. This baby's intubated. This baby's getting air flow just through the nose, but at high pressure. So we have a standard. It's just a standard in medicine that you gauge how much pressure you're pushing based on what a column of water that many centimeters high is. So a lot of times, like this baby over here is on a pressure of 7. And so what happens is even when the baby breathes out, it's pushing back with that pressure of 7. And what that's doing is helping the baby to keep their lungs open until they can figure out how to do it themselves. It's kind of like when you blow up a balloon, right? So the balloon's totally collapsed, and it's so hard to get it started. But once it gets started, it opens really easily. Well, with us, when we breathe out, your balloon goes down, but it doesn't fully collapse. Your rib cage and back pressure keeps it open so that it's easy to breathe. Well, in a newborn, it wants to collapse, and we want to avoid that, because every time the baby takes a breath, it's starting over, trying to open it up. Whereas if we can keep it open, then it's easier for them to breathe. It decreases their energy. Next slide. So there's the umbilical cord. Sometimes I did this just the other day on a baby. We had a baby born at 27 weeks, which happens to be the same amount of weeks Olive was when she was born. And that baby, I went ahead and put a plastic catheter in the umbilical cord. So if you follow down here, this would be the umbilical cord, and if you cut it, you see 3 little holes. One of them is a vein, and that's a real big one, and 2 of them are arteries. Those are kind of tiny. And if you put a plastic catheter, it's like an IV, in that vein, you can thread it up into the chest, and then you can use that to give fluids without having to stick the baby over and over again. Because if you put an IV in their hand, it's hard to get, because those veins are so tiny, so you end up sticking them 4 or 5 times just to get that. And then when you do get it, after about 24 hours, it blows, what we call it blows, but in essence, it comes out. And you can't use it anymore, so then you got to do it again. So when babies are born premature, I put in this catheter, and it allows me to give them nutrition, kind of the same way that mom's giving it to them, because that's what that umbilical vein is for. When they're inside mom, all of the sugar, protein, vitamins, fat are all going across that. And we can then duplicate that, not as good as mom can, but we can do pretty good with it until the baby's able to tolerate feedings. If you look at the next slide, this is an x-ray. It's kind of hard to see, but these are the catheters coming up. This one sits on the left side of the heart, so that's in the artery. This one comes straight up and sits on the right side, so that one's in the vein. And so we can use those in order to provide nutrition, antibiotics, any medications that the babies need. And those are pretty commonly done. The rest of this x-ray, those little things going sideways are ribs. This is the baby's stomach right here. It's full of air. And then this is the baby's heart, if you can see this outline right here. So, and this baby's also ventilated. There's an ET tube coming down, and it's sitting right about here, which is a little bit low. It needs to be pulled up to about here, because if it goes down too low, it's going to go down onto the right side, because if you look at your bronchi, they come down and then it tees off or looks more like a Y, but the right side is kind of more of a straight shot, and so if it goes in too far and then all the air is going to the right lung and you're not using the left lung, and the baby you need to be using both. So you got to make sure that the tube's in the right locations. Next one. Almost done. This is just a side view to look at those lines. Okay, next one. So here's another baby born. This one's on a ventilator. Also has probably this umbilical catheter, this little line going in through the umbilical cord. All right, next one. We have to get to our star. This is me taking care of a baby. Baby's in a little incubator. So the whole reason why we put him in an incubator is because we can create higher humidity inside that incubator, which keeps the babies from losing heat and water through their skin. We could also have the temperature inside that incubator higher than the temperature in the NICU. So it provides a protective environment for the baby. Okay, next slide. We'll just keep moving on. So these are just all the different things that we need to keep track of in babies in order to address each issue that they may have. Mm-hmm.
Do you help deliver the babies?
No.
Oh, okay.
I was in a delivery the other day and they said, we might need you over here to deliver. I'm like, I have not delivered a baby in about 30 years. I've done them before, and a lot of times they just kind of deliver themselves. They come out until they get stuck. And if then you want someone who really knows how to do that. So I try not to be the one to deliver a baby.
Delivery room if they suspect something's going to be wrong.
Yep. I tell them I'll go to any delivery you feel you need me to be at. So, yeah.
So, but what happens like when the baby comes out and they're stillborn? So is that where you come in and try and I guess like work?
It depends. So if you've been, a lot of times we'll trace the baby's heart rate during labor, and if you have a good heart rate and then all of a sudden some major event happens and it just drops and you can get that baby out in a few minutes, then there's then a lot of times those babies all resuscitate. And I had one baby, probably the longest without a heart rate was 11 minutes, and then got a heart rate at 11 minutes. And that baby actually ended up doing really well. She's like 12 or 13 now. Well, maybe not 12. Anyway, she's like maybe 10. And she's normal intelligence and doing really well. That's the longest without a heart rate. But if they're at home and then they come in and then they don't have a heart rate and they're stillborn, unlikely, because that could have been going on for hours. And really, once you get past 20 minutes, there's too much brain damage that
then
it's
do you
not going to help.
pronounce the time of death when they come out, or do you pronounce?
Well, it's just considered a stillborn, and you're not really giving it a time.
Oh.
Because it could have happened the day before.
So then what do you guys put on like the death certificate?
We don't normally do a death certificate for a stillborn.
Oh, okay.
Yeah, but you do report it, and it is kind of kept track of.
Even do a birth certificate, or?
No, I don't think you don't do a birth or a death certificate in those cases. But you do report it as stillborn, because we keep track of that stuff too, to make sure. So why do we keep track of these things? You're like, well, why would you do that? It's people's personal stuff. Well, because if you found that there was one area that had a high number of stillborns, you'd want to say, what's going on there? You know, so then you can go and look. Those are called epidemiologists. That's an awesome job. It's kind of like doing murder investigations, but it's more like illnesses. Like there was a number of kids in, I want to say it was El Salvador, but it was somewhere in Central America, that all of a sudden were getting kidney failure. And so they thought, well, maybe this is a new virus. And so they sent in a bunch of epidemiologists. And it turned out that there was a company that was creating a Tylenol type medication, but they were using antifreeze as the fluid to put it in. And that was causing kidney failure in all these kids. So anyway, so epidemiologists go in and figure, okay, what's going on? So if we saw, Southeast Missouri, all of a sudden there's a bunch of stillbirths going on there. What's going on in Southeast Missouri to figure that out? Memphis had an increased risk in a bunch of babies that were having strokes. And like, well, why is that happening? So it turns out that nobody was giving vitamin K at this one birthing center. So in vitamin K, babies are deficient in that, and they need that shot at birth. And so they were able to go in and say, hey, we need to change this because babies are having strokes. Yep.
Are you in the room for C-sections?
Yes.
Okay.
Yep, so you got to be in there, because I don't take the baby out, but I want to be as close to the baby as possible to take care of them. So.
You.
She's
Okay. Yeah.
Yeah.
You can ask him at home too.
No.
I love it.
Next,
I don't know.
next slide. All right, almost getting down. So here at Southeast, we take care of babies down to 27 weeks. The smallest ones I kind of take care of here are 800 grams. Once they get below 500 grams, which is right at about a little bit over a pound, those babies really, I think, need to be up in, a hospital that has surgeons and neurologists and heart doctors all available for those babies. So a lot of times those babies will send up to St. Louis. We take care of babies with respiratory disorders, heart disease, seizure disorders, nutritional issues, infections are common. Next slide. An interesting thing, and we're starting to see an increase in syphilis in our community, and that was something I had not seen for like 20 years, and I've probably taken care of 6 babies with congenital syphilis in the last year. And it's just because once it starts to kind of take root in the community, it gets passed around, and so now we're starting to see that. So that's another thing where your epidemiologist would look at it. So it's a sexually transmitted disease, but it can cause severe infections in babies. It can cause neurologic conditions and stuff like that. So, our goal, of course, send a healthy baby home. So what do I need a baby do in order to go home? Well, I need them to keep their temperature up in a crib, because most people don't have incubators at home. So we need that. We need them to be able to breathe well, and to be able to, babies when they're born really premature have what we call apnea, which is when they just stop breathing for no reason whatsoever. And they do that because their brain's like, well, you're only 25 weeks, you don't need to breathe, and not thinking about how they're born. And so they need to stop doing those things, and normally they'll stop doing that around 33 weeks. And then I need them to be able to feed well and gain weight, because for a baby, probably the main energy they expend is eating. That's like them running sprints. And so those little premature babies, they eat great once a day, and it's not enough to grow. So you gotta wait till they're able to take 7 or 8 feedings a day, routinely, and gaining weight. So next, I think we're almost done here. Best treatment is prevention. This is my slide about universal health care. So if you look at the dark green areas, those are adults with bad health. So they rank every area in Missouri based on their health statistics of the adults. They do that by looking at obesity, diabetes, hypertension, strokes, cardiovascular disease. And a lot of times the blue areas, which is the having low birth weight premature babies, and so dark blue and dark green tend to go together. Not 100% together, but pretty common. So there's certainly a correlation between the health of the community and whether or not you have premature babies. Next. Cigarettes, if you're smoking, the baby's smoking, so we don't want that. Just because things are legal doesn't necessarily mean they're healthy. I think we all know that. I mean, Big Macs are legal, but next one, chicken wings. But there's hope. Next slide. So we change the world one life at a time. So I think like if you fix one life and it's yours, that's awesome. You've done something great. Now if you can do that, then go help someone else, that's great. And if you can do it to another person, that's amazing. But one life at a time. Take care of yourself first. Because if you're not in a good shape, then you can't do things for others. Next. So this little baby, this is actually Ty. This is my son Ty. But Olive was born at the same time, like both of them were born at 27 weeks. Both of them are almost the same size. So this is what Olive looked like at birth. And then if you look at the next one, this is Olive when she was 3 years old. And this is Olive today. That's my talk. Olive was briefly on a ventilator. She was on a ventilator for about 24 hours. And then we were able to get her off onto those little nasal prongs. And she was in, And now she can walk on a beam. And she can do back flips and stuff like that.
I said I can't even get on the beam yesterday.
Oh, really? Have you stopped doing beam? I mean, I know you don't do it in chair, but you can do beam. Yeah. All right.
Okay.
I waited until she fell asleep. That you have what would be considered a normal caffeine intake. So I would say like 1 or 2 cups of coffee a day is not going to cause any problems for the baby. It does, caffeine increases your heart rate, the faster your heart goes, it pumps lesser amounts of blood with each pump, so that can have an effect. And it's a diuretic, so it causes you to pee more. And moms need to stay well hydrated in order to have good perfusion for the baby. So a little bit of caffeine is fine, but we do recommend those people who are drinking 5 to 6 cups a day or soda. Some people drink a lot of soda, to go caffeine to decrease that intake. It's good for women to exercise. Well, people ask that, can I continue to exercise? It is really good to exercise to keep your health up during a pregnancy. As you get further along, you're probably going to reduce your exercising just because it's hard to do when you're 8 months pregnant, I imagine. So, yes.
Is it good to do like backflips while you're pregnant? What?
I think at some point you might not be able to do a backflip because the baby's going to be bouncing around.
I've seen stuff.
Yes, I think we want to reduce the amount of backflips. You could probably do backflips during the early part.
Stephanie said, is it good to shake a baby?
I did not say that.
No, she does not. Everyone's going to get on. You are fine. Shake and go. But, so a goat doesn't need to do as complex of things as a human does as they get older. So we're trying to maintain that intellect and that ability to do calculus. Maybe if you shake them, they lose that. No, we never shake babies. Yeah, but like I said, they used to do that. Hold the baby upside down and spank his butt. Did you have a question?
Yeah, based on what you know, when do you think the population will reach 9 million?
I do not know. Couldn't even tell you what our current population is, but I would say that we keep seeming to go up, and I think that it probably creates some problems for our planet, and which then creates problems for us because we have to live on this planet. So probably in a way, keeping track of our population and making sure that we do it safely and healthily as we increase the number of people there. But I don't have any good ideas on how to do that because I'm not going to tell someone they can't have a baby. Babies are awesome. So, yeah. Anyway, so now that she's nice and asleep, so the first thing you do, most of the babies I take care of, even though I'm a neonatologist, you take care of intensive care babies because I'm in Southeast Hospital, I take care of more babies in what we call the well nursery than I do in the NICU, the intensive care nursery. And so the first thing you do is you just see the baby and you get a general impression of how the baby's doing. So if you look at this little girl, she looks really comfortable. She's not struggling to breathe. Her breathing, you can see her stomach rise as she breathes. But it looks very comfortable. She's not in any way at stress. Because she's sleeping, her tone is really loose, which is more common in a preterm baby. But if she was awake, I imagine her arms would be more flexed, because term babies, when they're awake, flex up. And you want to see that flex, because it tells you that neurologically everything is normal with the way they're stimulating their muscles. So that's the first thing you do, is you just get a look at them. And then normally I start head to toe, and I will gently reach around the baby and feel their head. And what I'm doing is I'm feeling for any bumps, and then I'm feeling the suture lines, because a baby's skull is not fused like yours and mine. A baby's skull has sutures, and the reason why is because the baby's head and brain needs to grow so much in that first year. And if it was fused, there'd be no way for that to occur. So those lines are open, and it allows the brain to grow and the head grow with it. So you feel the soft spot. And that's just an area where 4 different bones come together and they're not joined. So if the soft spot's not there, that would be concerning, because it would tell you that maybe those bones are already joined. And I saw a baby, actually they were twins, this was kind of crazy, but both of them had the same fused bone, this one on this side. And so there was still enough room for the brain to grow, but of course this side wasn't growing, so their head looked kind of lopsided. And that's something that can be treated. It's called craniosynostosis, and that's just premature closing of the suture lines. Before I get you too awake, I'm going to take a look in your eyes. So, and normally if their eyes are open, it's great, but if not, I'll just take a quick look. There we go, and that one looks fine. And this one looks fine too. All right, hon. She's like, what are you doing to me? And if somebody wants to look in somebody else's eye, that's fine. I don't think you should all pry open this baby's eyes, but afterwards, if you want to look in each other's eyes. So what am I looking for? I'm looking for what's called the red reflex, which is kind of like when you take I don't know if anyone's seen old photos of people and their eyeballs are all red and they look like little lasers. That's the retina reflecting light back. So it doesn't tell you how well that person sees, but what it tells you is the light hits the retina and reflects back. So that's what I'm looking at in her. So some of the things you might see is something like glaucoma, in which you don't see red, instead you see a milky color. So and that would alert you that there could be some type of endocrinologic disease or something. The other thing you might see is cataracts. Babies can be born with cataracts. And what that looks like is kind of like an eclipse, you know, where you have like the red ring of the sun and then it's dark in the middle. The cataract blocks the light, but since it doesn't block the whole pupil, you do see patches of red around it. And so that's what a cataract would look like. So she doesn't have either of those. So once again, it doesn't tell me how well she can see, but it tells me that there's nothing blocking light. The other thing about baby's vision is it's terrible. Babies can't see very good. You're really blurry to a baby, okay? And the reason why is because the covering of the eye, the lens, is really thick because it's been soaking in fluid. And so it thickens up. Once they're born, it starts to thin out. It takes about 2 or 3 weeks. So because of that, babies do really funny things with their eyes. They go cross-eyed, they drift into the corner, they twitch, they do all this stuff. And I tell families that's all normal, okay? It'll go away between 2 and 3 weeks. Hey, you woke up, huh? So then the next thing I do is I listen to their heart. And normally I want to listen to their heart in about 4 or 5 different locations. And the reason why is because you could hear a abnormal flow or something called a murmur. Oh, sorry, hon. And depending on where it's located, it'll tell you what might be causing it. So which valve might be leaking or which valve might be too tight that it's restricting the flow. If you think about how when water flows through something, you know, you have a hose, water's coming out, you put your thumb over it, and now all of a sudden it's spraying. So well, that same goes with the heart valves. So if the valve is narrow, it'll start to create this flow, this sound that's called, we call it a murmur. But in essence, it sounds just like a loud rush. So she does not have any of those, right? Okay, hon. Then I listen to her lungs. Oh, sorry, hon. And then you feel around their tummy, and they're making sure you don't have any masses, any like. I'm almost done with you. She's like, I was sleeping so nicely.
So cozy.
Yep. I'll leave your socks on. I'm gonna assume that your toes are okay. So some babies are born with something called club feet, and that's when their feet are bent in. Now most babies will have slightly bent in feet because they're in a tight location, but you can just easily move it into a normal spot. It's like this. If you can't easily move it, then that could tell you that that it might be stuck in that spot, and you would need to refer them to an orthopedic doctor for that. Then the other thing that's important to figure out is the baby's hips. Hey, because babies can have a dislocated hip. What happens is if this is like the femur, the head of the femur kind of bulges out and it sits in the hip and the hip wraps around it. But if it's dislocated, then it sits over here, the hip won't wrap around it and it'll end up flat. And so if you catch that when they're a year or two old, it's kind of too late to put it in the position to stimulate it to move around it. So what we do is we check their hips, and if there is a problem, if you take the hip and you put these little Velcro straps on it, called a Pavlik harness, and you stick it in the hip, then the hip will grow around it, and then when they're older, they'll be able to walk okay. Is there a pacifier? Yeah. There you go. She's like, oh. Okay. So then I check the hips by pushing back on it and rotating around, and I'm feeling for a pop. It almost feels like when your fingers pop, if you crack a knuckle or something, which you're not supposed to do, but you're feeling for that. If I hear that sound, I mean, I was told that, I don't know.
I know.
Like, everyone's like,
Don't pop your knuckles.
don't do that.
Your knuckles will double.
And her hips are fine, but if I heard that cracking sound, I'd be like, oh, this hip dislocates, and you'd want to treat it as a baby. Just take a quick look. You look like you got a little bit of a diaper rush. She can use some Desitin Creamy. Almost all diaper rash creams are zinc oxide, so I highly recommend zinc oxide. It doesn't matter which one you do. And then, right, yeah, beautiful eyes, hon. Then we're gonna check her back out. So you put the baby like this, and she's gonna like try to lift her head up, and check her spine, then check her. So you check the lower part of the spine to make sure there's not a little hole down there. She doesn't have all those. And then we put her back, right? I'm gonna get you wrapped back up. All right. What was her name? Did you say Anya? Anya. Everybody give Anya a hand. Way to go, honey. Does anyone have any questions about looking at a normal, healthy newborn like Anya?
Are the ribs like fully developed?
Yes, so the ribs are there, but interesting enough, the cartilage around the ribs is not very strong. And so that, especially in premature babies, so that's why their respiratory symptoms can be more dramatic. So they can retract or pull in between the ribs, or they can pull under, especially when they get any kind of respiratory infection. The cartilage of the larynx, which is the opening of your airway, can be really floppy in a newborn, and it causes a whistling sound when they breathe. Okay.
Oh, jeepers.
Okay. Well, look at your palate. Looks good.
You get to look at her mouth too.
Yeah, thank you.
So let me help you out.
All right. I think everything looks fine with this little one. I tell all moms and dads, Most important things are like safe sleep for babies. Babies should always sleep on their back. That's the safest way for them to sleep. It reduces the risk of sudden infant death syndrome. They should always sleep in their own space, a crib or a bassinet. And it's important that they're not co-sleeping with their parents, because they can get kind of nestled up against the bigger blankets and pillows, and they can start rebreathing their own air, which causes their carbon dioxide level to go up. They also can get overheated because we generate a lot of body heat, and when two bodies are together, they get even hotter. So those are all reasons why it's best for her to sleep in her own space. Right, hon?